Lovely. Okay. So, like I say, welcome to our webinar on non-invasive prenatal diagnosis. Before we start, just a little bit of housekeeping. If we can ask you to complete the pre-event survey, I've put the QR code on the screen in the corner there. Just use your smartphone or tablet just to scan the QR code and just complete a couple of questions. It won't take very long, but like I say, it's really important for us to gather information about who's here and what you want from these events as well. We are recording the session, and that's because we know that many people who would like to attend a course are working clinically or in the laboratories. And so we just want to give people the opportunity to watch it again at a later date. And so we will share the link to the recording with everyone who's attending, and it will also be available on our website and our YouTube channel. So because we're recording it, please turn off your camera and ensure that your microphone is muted during the presentations. There will be an opportunity to ask questions at the end. And just in case anyone is a bit nervous about asking questions whilst it's being recorded, we will edit that out at the end. You can also put questions in the chat and we'll pick those up as we go along. So let's just have a look now. I just want to introduce you to our team today and what the next hour is going to look like. So like I say, my name's Karen Creed. I'm lead midwife at Central and South GMSA. And after this slide, I'm going to hand over to Beth Young, who is our principal clinical scientist at Birmingham Women's Hospital, where we have one of the 2 NIPD labs in England. And she's going to give an overview of NIPD from the laboratory side of things. Then we're going to pass over to Steph Hart is a genetic counsellor at Leeds, and she's going to look at NIPD from the clinical genetics perspective. And then Denise Barnes, who's our lead midwife in North Eastern Yorkshire, GMSA, is going to go through where you can find out more about NIPD and genomics in general. And finally, at the end, we'll have a question and answer session. So I'm going to stop sharing my screen now, and I'm going to pass over to Beth.
Thanks, Karen. Let's see if technology works for me and allows me to share this. Has that worked?
Yep.
Yep.
Yeah.
Lovely. And let me just check it moves on. Has that moved on okay?
Yes, Beth.
Yay, wonderful.
Yeah.
Technology's on my side. Good morning, everyone. Thank you for that introduction, Karen. As Karen says, I'm Beth Young. I'm a principal clinical scientist at the West Midlands Genomics Laboratory, where I oversee our non-invasive prenatal diagnosis service. So to give you some introduction into NIPD, how is NIPD possible? Well, it's possible due to the presence of circulating cell-free DNA in the plasma. Circulating cell-free DNA is released from cells just undergoing normal programmed cell death as part of their normal cell life cycle. They break down, they release their DNA into the plasma. It's a very low concentration and it has a really short half-life, so it's turned over really quickly. It's really fragmented, and the important thing to remember is it's released from every tissue in the human body, because every tissue is turning over cells and breaking down. It's just natural proliferation of cells. So when a woman is pregnant, one of those cells that's releasing cell-free DNA is her placenta, and this is what we call cell-free fetal DNA. So although we describe it as fetal, it's actually originating from the placenta. We can detect it really early in pregnancy, from as early as 6 weeks gestation. As the pregnancy progresses, the proportion of cell-free fetal DNA in the plasma increases. And that's just because as the placenta is growing in size. And as I said before, cell-free DNA is really challenging to work with because it's sort of really small and fragmented. But cell-free fetal DNA is even more challenging because you're looking for it in a background of maternal cell-free DNA. I said that we can detect it from as early as 6 weeks gestation, and it does generally increase as the placental size increases, but it's really, really variable from not just woman to woman, but pregnancy to pregnancy. So this is a graph that I took from one of our papers where we looked at the fetal fraction versus gestation in, I think it's about 150 cases. And even as a non-statistician, I can see that that certainly isn't linear. So it's really hard when we're asked when's the best gestation to get the best fetal fraction. We just can't tell you. We just have to try it and give it a go. And that's because fetal fraction can be affected by many factors. That can be smoking, drugs, ethnicity, fetal health, placental health, maternal hypertension, but the most well-established one is maternal BMI. So women with a higher BMI have a lower fetal fraction in their pregnancy. And this was our study of just 150 cases. This publication from 2019 showed exactly the same profile with a study of, I think, several thousand women. So what are the different ways we can use cell-free DNA in prenatal diagnosis? The first two on this slide I'm not going to talk about today. There's NIPT, which is non-invasive prenatal testing, which is screening for aneuploidy of chromosomes 13, 18, 21. And this test has been part of the screening pathway since 2018. NIPT is, cell-free fetal DNA is also routinely used in rhesus D genotyping, and that can be used when mum herself is rhesus D negative and known to see whether the baby she's carrying is rhesus D positive. And this is offered as universal screening from as long as 2016. As I said, I'm not going to talk about either of these pathways today. I'm going to talk about non-invasive prenatal diagnosis. So that's where it's a diagnostic result generated from cell-free fetal DNA. And the two areas I'm going to talk about are determination of fetal sex and diagnosis of single gene disorders. I'll talk first about determination of fetal sex because that's the most simple assay we use and one we've been running for the longest time. We've been performing non-invasive fetal sexing here now in Birmingham since 2009. We will only offer it when the fetal sex is clinically relevant. So that's for sex-linked and sex-limited disorders, so pregnancies at risk of things like congenital adrenal hyperplasia or Duchenne's muscular dystrophy or haemophilia. So it is only possible when it's clinically relevant. We can accept samples from 7 weeks gestation, and it's a really simple test. All we do is look for Y chromosome material in mum's blood, because if we can find Y chromosome material in mum's plasma, it suggests that baby is male. Forgive me if I'm telling you things you know here. I've just put this slide in to show how what a PCR profile looks like, because that's what we rely on for this assay. So PCR is a simple reaction of heating and cooling that allows us to amplify DNA, and specifically a target region of DNA that we're interested in. And this graph here shows the number of cycles of your PCR reaction you're doing, and up here, the amount of PCR product you've got. So as the PCR goes along, it starts off, doesn't really see much amplification. You go through this exponential phase where the amount of reaction is doubling with every cycle, the amount of product you get, and then it plateaus out towards the end of the reaction. And as you can see, if you've got a no template control, you get no amplification whatsoever. So what we're looking for in a PCR reaction is that lovely sigmoid curve to show this amplification, which shows those target DNA to start with. So I'll show you two example cases. This case here, we've done the amplification of the SRY gene, the gene that's on the Y chromosome, and we're not getting any of that lovely curve. So we can say there's no SRY in this sample. But the problem with this is, how do you know that we're not getting SRY because there is no SRY and not because we didn't have any template to start with, or that the reaction hasn't worked? So we also include a control amplification. We use a gene called CCR5, which is present in everyone's genome. So you can see you're getting that lovely amplification here of the CCR5 gene, but nothing of the SRY. So we know we started with some cell-free DNA. We know our PCRs worked, but there was no SRY in the initial sample. So there's no Y chromosome in mum's blood. So we infer that the fetus is female. What I should say is the reason we're getting multiple curves here on this plot is we do the test in 8 replicates to ensure our sensitivity. So in this case, we would report this as fetus predicted to be female. In this second case here, you can see not only are we getting amplification of our control gene, but we're also getting amplification of SRY in every one of our replicates. So we can say this fetus is predicted to be male. Really simple, straightforward assay. There are some things you have to consider though. There is the possibility of a false negative result. And the reason for this is because you're inferring a female result. You're saying we can't detect any Y chromosome, therefore we predict the fetus to be female. And so it might be that just the cell-free DNA level was too low to be able to pick that up. And so if we do receive a fetal sexing sample, remember I said we can accept them from 7 weeks. If the sample was taken under 9 weeks gestation and we get an apparently female result, we would always recommend repeat testing to confirm, just to make sure it wasn't a false negative due to low fetal fraction. You can also get what we'd call a false positive result when a female pregnancy is called male. So we're seeing SRY, but the fetus is female. This is most often can be ascribed to a vanishing twin pregnancy. So where the pregnancy started off as a twin pregnancy, there was one male, one female. The male twin has demised, but there is still cell-free DNA in circulation. And we know that vanishing twins can occur in up to 0.7% of pregnancies. The other possible outcome is where we see evidence of SRY, but it doesn't meet our threshold. You remember I said we do 8 replicates for every sample, and we need to see SRY in every replicate. And for this, we would issue an inconclusive result. Again, the most likely reason is just the fetal fraction wasn't high enough yet, and a repeat sample would resolve that. So I'm going to move on from fetal sexing now to talk about NIPD for single gene disorders. There are 2 different methods we use to diagnose single gene disorders. We have bespoke NIPD, which as the name suggests, we design an assay for a particular variant the family carries. Or we can do RHDO, which is a linkage type assay, and we can use that for DMD, BMD, SMA, Duchenne's and Becker's, spinal muscular atrophy, cystic fibrosis, and CAH. I'm going to talk about both of these in a little more detail now. So I'll start off with the bespoke NIPD assay. Oh, sorry, I should also have said that our NIPD service here at Birmingham was established from funding from the NIPD study. We were funded by the Health Innovation Challenge Fund, and this helped us to set up a service for NIPD and translate them into a clinical setting. So to go back, as I said, there's 2 types of NIPD I'd like to talk to you about. The first one is bespoke NIPD for single gene disorders. We use bespoke NIPD for looking at variants that aren't present in the maternal genome. So they're variants that are either the fetus could have inherited from dad, or they are de novo, having arisen in the fetus. So this assay cannot be used for maternal inheritance. It is just paternal or de novo. I mentioned earlier that cell-free DNA is really, really fragmented, so we can only use assays to look for very small variants, whether that be a single base pair change or very small insertions, deletions, and duplications. And as I said, we work up an assay for every family. We do a bespoke assay, and that can take a few weeks. So we do ask that we are contacted ahead of the couple becoming pregnant so that we can do the work and have an assay ready to use for them in pregnancy. I do appreciate that that's not always possible. We do know that some couples will turn up already pregnant and want to access this service, and we're happy for you to contact us in that scenario, and we will do our very best to get an assay ready for them to use in an appropriate time frame for that pregnancy. So these pictures here are just to show you now the 3 scenarios in which I can offer bespoke NIPD. I can offer it, if you look at the middle schematic here, if dad is detected with an autosomal dominant condition. We can look for his variant in mum's plasma. If we see his variant in mum's plasma, it must be coming from the fetus, and we will predict the fetus is affected with the same condition as dad. We can also do it for a couple where they've had a previous pregnancy affected with a de novo variant. So neither mum or dad carry the variant in this scenario. They've had a previously affected pregnancy. There is a very slight recurrence risk, so we can look in future pregnancies for that same variant. I should say, however, that this scenario isn't currently funded by the NHS because the recurrence risk is so low. And then the third, slightly more complicated scenario is for autosomal recessive conditions. Excuse me. In autosomal recessive conditions, the child is at risk of inheriting a variant from both mum and dad, and they need to inherit both of those variants to be affected. If mum and dad carry different variants in the same gene, we can design an assay to look for dad's variant in the cell-free DNA. If we don't pick up dad's variant in the cell-free DNA, we know the fetus won't be affected. They might be a carrier of mum's variant, but that's not really relevant prenatally. And so no further testing is required in that pregnancy. If we do pick up dad's variant in mum's plasma, we know the fetus has inherited dad's variant and so is at 50% risk of being affected. And we do require an invasive test then to look for mum's variant. So NIPD in this scenario isn't always fully diagnostic, but it reduces the need for invasive test by 50%. And I was just going to show you a couple of case scenarios now that I hope demonstrate that more clearly. Oh, sorry, I've put in slides I've forgotten about. What I should say, the assay, again, I mean, I love the simplicity of NIPD. It's really difficult material to work with, but the assays themselves are quite simple. I talked about PCR being a method we can use just to amplify a target region of DNA. All we do is design a PCR assay that flanks the variant that's in that family. We perform really high depth next generation sequencing. To put that into some kind of perspective, most assays we do by next generation sequencing, we want a depth of sequencing, and that means the amount of data we get, to be a minimum of 20 reads. When I'm doing this assay, I quite often get 500,000 reads. So really sensitive assay. And we also do another panel of markers that we will use to calculate the fetal fraction, so we know there's fetal DNA in the sample we're testing. And so far, we've developed assays for more than 200 different genes. And we've performed more than testing NIPD for more than 250 pregnancies. So this is a couple of examples I said a minute ago I was going to show. This is a pregnancy at risk of Noonan syndrome. Dad is affected with Noonan syndrome and has a variant in the PTP-N11 gene. And so the pregnancy is at 50% risk of also having Noonan syndrome. We worked up an assay for dad's variant and we sequenced dad's DNA, mum's DNA, and a plasma sample from mum. So you can see here, I've done it in two ways to show this because I know some people prefer tables and some graphs. So mum's genomic DNA, we can only see the variant. You'll always get a little bit of background. So in mum's genomic DNA, we can see negligible reads for the variant. For dad's DNA, we're seeing it, you expect it to be around 50%, but we do get some variation between 40 and 60. So we know we can pick up the variant in dad's DNA. We know it's not present in mum's genomic DNA. And then we've looked at her plasma. Oh,
Do you fancy?
Oh, sorry, is everything okay?
Oh,
Yeah,
sorry.
That's all right. We looked at mum's plasma and we can't see the variant in mum's plasma either. Now, in order to make sure that wasn't due to too low a fetal fraction, we do our assay. And we know that the fetal fraction was over 4% of the DNA in mum's plasma was coming from the fetus. So that's great. We can't pick it up. We know it's there. We also run some plasma controls because, as I said, you always get a little bit of background and you want to make sure that your normal plasmas give the sort of same level of background, which they did in this situation. So we could say from this that this fetus hasn't inherited dad's variant and so won't be affected with Noonan syndrome, and no further testing is required because, as I said, this is a diagnostic standalone test. Oh, sorry. Typical. This is an example of a pregnancy at risk of a recessive disorder. So in this situation, this couple have a child with cystic fibrosis and they both carry different variants. We've worked up an assay for dad's variant, the Delta F508, which actually is the most common cystic fibrosis variant. And again, we've performed sequencing of mum's genomic DNA, dad's genomic DNA, and mum's plasma. Again, we can see the variant in dad's genomic DNA, but not mum's genomic DNA. So we've shown that the assay worked. And then we look at mum's plasma sample and we can see the variant in her plasma at around 4%. So if we're picking up dad's variant in mum's plasma, it must be coming from the fetus. So we know in this scenario, the fetus has inherited dad's variant, is therefore at a 50% risk of being affected with cystic fibrosis. But we need to do an invasive test to see whether mum's variant has been inherited as well. So this couple did go on to have an invasive test, And it actually was good news. The invasive test did confirm the presence of dad's variant. The fetus was a carrier, but not mum's variant, so not affected with cystic fibrosis. As I said, though, I mean, I know this couple still had to go in and have an invasive test, but if we hadn't picked up dad's variant, there was a 50% chance we wouldn't. No further testing would have been required, and that fetus then in their life could then go on to decide to have carrier testing as and when was appropriate, but it's not relevant prenatally. I hope that makes sense about bespoke NIPD. That's all I was going to say about it for the minute, and just move on to RHDO, which is the slightly more complicated technique, but I'm happy to take questions at the end if there's anything that's not clear. So the slightly more complicated technique we use is one called relative haplotype dosage, or RHDO. It's much easier to say. This is a technique that we adapted from a method that Dennis Lowe first published in 2010. And Dennis Lowe is sort of the godfather of cell-free fetal DNA. And Lowe et al. Published in 2010, they are able to work out the genome-wide genetic profile of a fetus looking at the cell-free DNA, which is just crazy. I think that's amazing that looking at mum's plasma sample, you can have the whole genome of the fetus. But obviously that's not practical for routine clinical use. It's far too costly. So we've developed it using that NIPD project to just target regions of disease genes interest. As I said, we can offer this technique for cystic fibrosis, SMA, congenital adrenal hyperplasia, Duchenne's and Becker muscular dystrophy, and also retinoblastoma. So what we've done is create assays for each of those 5 disorders, but then we combine the assays so that we can multiplex. What I mean is by that is we can run samples from several different women with pregnancies at risk of several different disorders all in one run on our sequencer, and that helps to reduce the cost, because this assay is very, very expensive. So we can only offer it for common disorders where we're going to have quite high throughput. Now, this assay is different from bespoke NIPD because we're not looking for the variant directly. Instead, what we're doing is tracking the inheritance of the chromosome that has the mutated genes on it. And because we're doing that, we need to have a proband sample to phase the haplotype. So with the previous example with bespoke NIPD, we didn't need to phase the sample, we just needed maternal and paternal DNA. In this, we need DNA from a previous affected child so we can do what we call phasing the analysis, and I'll show you hopefully that in a bit more detail in a moment. Hope it'll make more sense. As I said, this assay doesn't look for the variant directly. It's what we call a linkage-based assay, and we use using single nucleotide polymorphisms. So these are just normal variation within the genome. As with every assay, it has its advantages and disadvantages. Its advantage is it can detect maternal and paternal inheritance. So when I showed you before about the bespoke, we can only look for paternal inheritance. We can only look for things that aren't present in mum's genome. This assay, RHDO, we can give you a full diagnostic picture of both mum and dad. Again, the bespoke, as I said, it was limited by the type of variant because of the fragmented nature of cell-free DNA. That's not the case in RHDO. And we also don't need to do a workup in advance. We can use the same assay for every couple at risk of, with their pregnancy, at risk of one of these disorders. It does have disadvantages though. As I said, we need the couple to have had a previously affected child so that we can phase our analysis. This assay wouldn't pick up a de novo change, a new change that was acquired in this fetus. And at present, we can't offer it to consanguineous couples because we can't differentiate between the haplotypes of the chromosomes in couples who are closely related. If anyone was interested, these are our publications back from 2016 and 2017, where we showed our validation of the assays when we first launched them. And we saw for all 4 disorders we were testing at that point, we had 100% sensitivity and specificity, which is great news. It shows that this result can be used diagnostically and doesn't need further confirmation. We ask that samples for NIPD are taken a little bit later than those for fetal sexing. That's just to get our fetal fraction up, but we can still offer it from 8 weeks, so very early in pregnancy. We can only offer it for singleton pregnancies. And that's because if you think about, we're already dealing with a plasma sample with maternal and fetal DNA in it. If it had 3 genotypes, it just wouldn't be possible to differentiate between them all with the technology as it is present. Hopefully one day we'll be able to do that. For X-linked disorders, so Duchenne's and Becker muscular dystrophy, fetal sexing needs to be performed first, so we will only do the testing for male pregnancies. But what you can do is you just send us in 2 samples. We'll do the fetal sexing, as I talked about a few slides ago, and if the pregnancy is predicted to be male, we just reflex onto NIPD. We need to know the parent's carrier status to be able to interpret the results appropriately. And the samples that we need, as I said, genomic DNA from mum, dad, and a previously affected child, and then a fresh blood sample from mum, from which we can separate the plasma and extract the cell-free fetal DNA. Now, I quite blasé said it's a linkage type assay, assuming that everyone knows what I mean by that. And I realise I'm quite an old school geneticist now, and not everyone uses the term linkage analysis anymore. So I'll show you what I mean by that. So if you remember, I said with a bespoke NIPD, we're doing a sequencing assay to look directly in the plasma for the presence of the variant. We're not doing that here. What we're doing is tracking a pattern across the gene of interest to infer what the fetus has inherited. So the reason we need a proband, a previously affected child, is we need to do what we call set the phase. And to do that, we look at the 2 chromosomes of interest. So say this is a pregnancy affected with a child affected with cystic fibrosis. This is the CFTR gene. And we know, oops, sorry, I'm getting too carried away with my animations. What we do is look for a pattern of SNPs, single nucleotide polymorphisms, that are associated with these chromosomes that this child inherited from both mum and from dad. We then look to see the same pattern in mum and dad, so we can establish that this one here, we know this blue chromosome is the maternal chromosome that the previous affected child inherited, because they have that same pattern of markers across the gene. And mum's other chromosome, we're not seeing these markers in her affected child at all. So we know that this chromosome is not associated with disease. It doesn't have the variant on it. And we do the same for dad. We look at his 2 patterns. He's got this yellow profile of markers that were in his affected child. So must be on the copy of the gene that carries the variant. And then this purple copy, this pattern of markers wasn't present in his affected child. And so is his copy of the gene that doesn't carry the variant. So what we're doing when we do NIPD now is we're looking in the current fetus for this blue pattern of markers and this yellow pattern of markers. And if we can see those in this fetus, we know they've inherited the copy of the gene with the variant on. So, sorry. Now I showed you that schematic using 4 markers. We actually use our SNPs we use as markers. For the Duchenne's and Becker muscular dystrophy, we look at 1,800 SNPs. And for CF, we look at 2,951 SNPs. So I showed you that quite simple analysis of markers, pattern of markers based on 4. But when we do it in a real pregnancy, we're looking at literally thousands of markers. So we can get it really, really sensitive assay, saying, has this current fetus inherited the same copies of the chromosomes that the previous affected child did? And to ensure our sensitivity is as high it can possibly be, we actually generate blocks of the SNP. So we don't do all 1,800 in one row. We look at 25 blocks at a time, saying, right, is this block of SNPs the same pattern as was in the previous affected child, or is it the pattern that wasn't in the previous affected child? And what you end up with is a pattern like this. So you've got the dystrophin gene here marked in orange, and each of these arrows, represents a haplotype block of 25 SNPs going all the way across. And what we've shown here is that for this fetus, they've inherited the same pattern of SNPs as the couple's previous affected child. And so we can infer they've inherited the same X chromosome as the previous affected child, and so has inherited the pathogenic variant and will be affected with Duchenne's muscular dystrophy. When we're looking at autosomal recessive conditions, we obviously do have to do the analysis twice because we're interested in both maternal and paternal inheritance. As I said, we can't offer this test for multiple pregnancies because that just throws out all our ratios, and we can't. It's really hard. You can't differentiate between 3 genotypes. We do assess the fetal fraction, and if that's low, again, it can make the result unclear, and we may ask for a repeat sample. As I said, we don't currently offer this testing for consanguineous couples because that reduces the number of SNPs we use, because quite often the couples will have shared patterns. You'll see the same pattern between the 2 different chromosomes, and you can't differentiate between the low and high risk chromosome. The test doesn't look for mutations directly. It wouldn't pick up at something new that had arisen in the pregnancy. And this assay can pick up recombination events, so that's when you get a crossing over of the chromosomes. And when you have that, this is the kind of pattern we see. So the blue arrows represent the low risk haplotype, and the red the high. We can see quite clearly that a recombination has occurred. So this fetus, somewhere in the development of this fetus, the X chromosomes have gone through a recombination event, so they've crossed over and separated again. So you've got a part of the low risk X and part of the high risk X. But because we plot on the site of the familial variant, shown here in purple, you can see that falls really well in the middle of the high risk X, so we can still say that this pregnancy is affected. However, I would say we're always super cautious, and if we're not clear on the result, we will recommend repeat testing. I'm sorry, Karen, I realise I'm going over, so I'm going to whip through the next few slides. So we've been offering this service since 2016, and we've grown it as we've gone along, adding in more disorders. We have a turnaround time of 14 days for testing, and the cost of the test is £1,300, but this is funded by the NHS. Our referral numbers have increased over the years, and to date we've tested over 700 pregnancies across the UK and internationally. So for some of these disorders, as far as we know, we're the only lab in the whole world offering testing, and so we've received samples from as far afield as New Zealand. It has a very low failure rate. And where we have performed audit with any follow-up testing that might have been performed postnatally, we have seen 100% concordance. As I said, this follow-up testing isn't required. It's just we do say if the couple are willing to have it on cord blood, it's good for us to audit our service. I think this graph is quite interesting. So as I said, we can detect the samples, we can accept samples from 8 weeks gestation. And it takes us around 2 weeks to turn around a result. Our mean is 11 days. So as you can see here, showing the sample of when the NIPD samples were taken, the majority of couples are getting an NIPD result before they've even reached the gestation where a CVS would be possible. So not only are we giving patients, couples, families information in an invasive, low-risk way, we're giving them that information very early in the pregnancy, which helps to make informed choices. And again, for anyone who's interested, a couple of years ago, we published our experience for our first 152 cases. I think you can just download this for free, but if anyone wanted it and wants to drop me an email, I can send you a PDF of it as well. So don't pay any publishers for it. I have the PDFs. And just to finish off with where we want to go with the future of NIPD, ourselves and Greater Ormond Street and Yorkshire North East were part of a prenatal genomic network of excellence group. We're looking at different ways we can improve prenatal testing. And one of the things we're looking at is how we can expand NIPD. As I said, at the moment, RHDO is only available for 5 disorders, and we're looking at what other tests we can offer, what other disorders we can offer this testing for. Like I said, it has to be something quite common in order to account for the cost. So the area we're looking at the moment is hemoglobinopathies, and ourselves and Great Ormond Street are both working on assays that we should hopefully be able to offer for pregnancies at risk of hemoglobinopathies in the near future. And we also want to expand the testing acceptance criteria. We're about to launch RHDO for consanguineous couples, so we've had to develop a new method, but I should hope from next month onwards we'll be able to offer NIPD by RHDO for consanguineous couples. We're also looking at techniques that would mean we could do RHDO without having to have that reference sample to phase the analysis. I find it really hard to have to say to a genetic counsellor who approaches me, I'm sorry, this couple haven't had an effective pregnancy, we can't offer RHDO. Hopefully soon we'll be able to do it using new technologies. And then the more challenging area is an NIPD for maternally inherited variants. However, I do know that the lab in Exeter currently offer NIPD for maternally inherited variants associated with MODY, diabetes, and also there are some publications in the literature where targeted massively parallel sequencing, so again really high depth sequencing being performed to look for maternally inherited variants, but apart from the Exeter work for MODY, this isn't currently available in routine clinical practice. And so apologies, Karen, I'm massively gone over, but this is want to just thank everybody who's involved in this service. We've been offering it now for nearly 10 years and we're really proud of it.
Thank you, Beth. No, that was amazing. I find the science quite challenging for my brains, but you explain it so beautifully, especially with the case studies. And I think it's really exciting to hear where this might be going in the future. So thank you so much. Time is moving on. So let's move on to Steph. So Steph is our genetic counsellor from Leeds. I'll hand over to you, Steph, if you want to share your screen. Thank you.
Great, thank you so much. Can everyone see my screen?
Yes.
Perfect.
I can see your slides. Perfect.
Oh, sorry. Yes, my slides. Thank you. And thank you so much, Beth. It always blows my mind a little bit thinking about sort of the science behind NIPD, and I think it's such an amazing technology, and it's such a great option to be able to offer to couples. So hi everyone, my name is Steph. I'm one of the genetic counsellors part of the Leeds Clinical Genomics Service, and I'm so very happy to speak to you today a bit about NIPD from a clinical genetics perspective. Hopefully my slides are moving. Oh, they're not moving for me. Oh, why is that happening? Sorry. Has that moved on for you guys?
That's just moved on. Yeah.
Perfect. Lovely. So today I'll talk to you a bit about sort of the genetic side of things, so referrals to clinical genetics and what happens in a clinical genetics appointment, and finally go over some examples today. And I want to start really by sort of talking about NIPD and sort of how valuable an option it is to offer couples. And I think Beth really highlighted that in her appointment today, in her talk today. So as is key in the name, non-invasive prenatal diagnosis allows us to be able to offer couples where it's suitable for a non-invasive testing option in a pregnancy. We see many couples who want to be informed about the risk of a genetic condition in a family, but for them, the associated additional risk of miscarriage for a invasive procedure such as CVS or amniocentesis just is unacceptable for them. But NIPD, where it's possible, allows them to be able to gain information in a pregnancy and make them informed decisions in a pregnancy in a non-invasive manner. And as Beth has also mentioned, where it's possible, we can offer it very early on in pregnancy. And you may know from conversations from women, obviously having information about the risk in a pregnancy is always often better knowing about it earlier on. And so it's really great that this is something that we can offer from around 8-9 weeks in pregnancy. And as Beth highlighted there, by the time the results available in a couple of weeks from that, we usually can advise patients about the result of the testing in a pregnancy prior to a stage when CVS or amniocentesis may be carried out. We also know with the CVS and amniocentesis there can be delays in reporting times for those invasive procedures as well. So it's a really great technology, and it's been so fantastic to be able to offer couples these options. So I'll move on to, and sorry, what I should also say is that I'll be talking a lot about the pathway in Leeds, but just to really stress that the pathways may differ between different genetic services. So it's always best to contact your local genetic service if you do have any queries about the pathway. So who can refer to clinical genetics? So many people can refer, but what's most important is that all of you can refer to us. And we really, really want to stress this, because for us, early referrals to genetic services allow us to be able to see couples very promptly in a pregnancy and really discuss their options in the best time appropriate manner. If we receive referrals for patients later on in pregnancy, particularly sort of after 15-16 weeks, and particularly if they're considering testing in the pregnancy, that can raise additional issues around sort of reporting times, and particularly if they would alter their management in a pregnancy. So I suppose one really key message from today is that please do refer to us, and ideally what we'd love to see is if midwives, community midwives, are aware of a family history of a genetic condition through a booking appointment, please do refer on at that stage. That 8-week, 9-week gestation is a great time for us to receive referrals for women who are pregnant or even earlier. So please do refer to us, and we are very happy to receive referrals directly. Just to highlight that within Leeds, all our region, we have the GAP, which is Genetics Advice in Pregnancy, which really encourages midwives to contact us for advice in pregnancy. So I know that we're very happy to receive queries as to whether a referral is suitable. So please do get in touch with us and your local genetic service if you do have any, if you are wondering if a couple would be eligible. So yes, please do refer to us as soon as possible, would be very, very helpful. Thank you. So what's really helpful to be included in a referral? So obviously the details about the pregnant person, their gestation, their EDD, do they have any medical concerns? If they're the person at risk of a genetic condition or have the genetic condition, have they had testing? Details about the partner, particularly if the family history is on their side of the family, as much details as possible about them, and what the condition is in the family, who's affected, and details about any affected relatives as well. And it's really helpful to know if any genetic testing's been carried out and if a family member has been seen by a genetic service. And those can really act as red flags when going through a booking appointment. If anyone in the family's been seen by genetics, that could sort of prompt potentially a referral to genetics. And like I said earlier, a referral as early as possible in pregnancy is very great, or before. So we do see couples preconceptually to go through their options for a pregnancy. So what happens in a clinical genetics appointment? So in Leeds, most of our appointments are done virtually, so over video or telephone call, and they usually take around 30 to 45 minutes. So we will meet with the pregnant person or with their partner if possible, and discuss their personal history, their medical history, and the family history as well. And I'll come on to that in a second. And we go through their testing options. So what's really important for me to highlight is that as genetic counsellors, we practice a non-directive approach. So I'm not here to guide any particular decision over another decision, but my job is to make someone aware of what options are available to them in a pregnancy and support them in making the decision that's best for them. So we really help sort of promote a patient's autonomy in that area. And we go on to then organise the testing if that's what a couple would choose to do. So in genetics, we love family histories. It's our bread and butter really. So I've included here today 2 examples of 2 family histories. So family histories are great because, one, it's a really great way to sort of develop a rapport with a patient. We learn a bit about their family and the connections in the family. And obviously it gives us really helpful information about what the risk may be for the person and the pregnancy as well. So the family tree on the left, so what we can see here is that it's a genetic condition. So what I should say is that the black squares or the black circles are people that are affected by the genetic condition. So what we can see in this family history is that multiple generations are affected by the genetic condition. And I'm really sorry if you can hear some background noise. My daughter's off sick from nursery with chickenpox. I'm really sorry if you can hear any background noise. So what you can see in the pedigree on the left and the family history on the left is that multiple generations are affected by the genetic condition in the family, and we can also see that both men and women are affected. So that tells me that it's very likely to be an autosomal dominant genetic condition. So autosomal means that it affects both men and women equally, and dominant means that if someone's affected by the genetic condition, their child, their pregnancy, has a 50-50 chance of having the condition as well. The family history on the left, so the red square is the individual affected by the genetic condition. So looking at this family history, I think that maybe it's one of 2 types of inheritance patterns. So there's one inheritance pattern called autosomal recessive. So this is where we typically see one generation affected by a genetic condition, and both boys and girls can be affected. And usually parents of a child with a recessive condition are both carriers of that condition. So where two parents are both carriers of a genetic condition, there's a 1 in 4 chance that their child may be affected by the genetic condition. This family tree could also represent an X-linked condition, so where mum is a carrier, not affected herself, but could at risk of having an affected male. So that's also the case here. So by taking a family history, we learn so much about the family history, and also if we do need any samples to help develop the NIPD assay, we can also sort of learn from the family tree who we need to contact and what samples we may need. So after talking about a family history, we usually go on and talk about the condition in the family, what that means, if there's any variability, and then explore a couple's views about testing in a pregnancy. So just to stress that not all couples choose to have a test in a pregnancy, whether that's a non-invasive or invasive test. And so some couples may choose to find out after birth, particularly if it's a genetic condition with a childhood onset. So that's something that we can arrange in clinical genetics. Or if it's a genetic condition with an adulthood onset, that testing could be considered for the child when they reach adulthood. So if NIPD is something that's possible for a couple, and it's not always possible, Beth's gone through some of the scenarios where it may not be suitable for a family. So for example, if in a consanguineous family, it's not always possible. But if it's possible, we can discuss what that means, how it is carried out, and also explore other testing options such as invasive testing, or if there's a genetic condition that could present antenatally with scan findings, we may refer on for additional scans in a pregnancy, which could help inform whether the pregnancy is affected or not. I mentioned earlier that we see couples preconceptually as well, because there are options before a pregnancy, so particularly pre-implantation genetic testing. So we're also very happy to receive referrals before a pregnancy, particularly if a couple would consider going through PGT, which is essentially like an IVF process. If there is a significant risk of having a child with a genetic condition, and essentially that allows us to test the embryo for the genetic condition, and then unaffected embryos are implanted into the female partner as well. So when can we offer NIPD? So there is the National Genomic Test Directory, which dictates what genetic tests we can offer to individuals and couples. And this highlights here exactly what NIPD can be offered for. And as Beth mentioned, there's 2 approaches, either the haplotype testing or the direct variant testing. So what type of approach would be offered for that testing? So this helps guide when and how we can offer NIPD to couples. So how do we do it? So if a couple wants to go ahead with NIPD, one of the first things we do is to try and arrange an early viability scan. So if we contact you asking if you could very kindly arrange an early viability scan, the reason for that is because we need to confirm that it's a singleton pregnancy and the gestation of the pregnancy, and of course that it is a viable pregnancy. So we try and do that, particularly where we know NIPD would be an option. We sometimes may contact local peripheral hospitals before an appointment if that is something that we can offer. Most NIPD, as Beth has said, is organised by Birmingham or Gosh as well. And as Beth has said, we may need to send DNA samples from the couple or a previous affected child to the laboratory to be able to offer NIPD, and our lab kindly arrange that. And then we need to arrange a blood sample from the mum for NIPD. And we typically use Streck tubes. So if we send you some weird looking tubes, the reason for that is because it essentially keeps the blood for longer and makes sure it reaches Birmingham in time for the genetic testing. So I'm just going to go through some case examples if we're still okay for time for a few minutes. Is that all right? I'll whiz through them.
Yes, Steph, you're fine.
Fab, lovely.
5-7 minutes.
Perfect, lovely. So I've just got a couple of examples that we could go through today. So Anna is 5 weeks pregnant. This is her first pregnancy. She's 22 years old. As soon as she finds out that she's pregnant, she contacts her GP and community midwife to make them aware of the pregnancy. And she tells her midwife that she's well, but she's known to be a carrier of DMD, so Duchenne muscular dystrophy. So this is a genetic condition inherited in an X-linked manner. So typically males are affected and females are carriers of the condition. But females can have some features of the condition, particularly the heart can be affected, and that can be exacerbated during pregnancy. So it's really important that female carriers of DMD have heart screening during pregnancy. Her partner George as well. So they want to have genetic testing in pregnancy, and Anna's previously had genetic testing to confirm that she's a carrier and that she knows that she's a carrier of DMD. She is already having heart screening, which is fantastic. So Anna asks her midwife to kindly refer her to clinical genetics. So we meet with Anna and we go through her options in the pregnancy. So of course, as we said, couples may choose not to have testing in a pregnancy, and for a genetic condition like DMD, we may consider testing sort of shortly after birth or in early childhood if that's what the couple would want if it's a male pregnancy. And there is also the option of NIPD or invasive testing. And as Beth mentioned, NIPD for DMD is done in 2 stages. So firstly, we determine the sex of the pregnancy, and if it's male, then they go on to do the DMD testing. So we've had a look at Anna's family history, and really it's all come about because her mum's maternal uncle was affected by DMD, and so subsequently carrier testing was arranged in the family. And as you can see, Anna's mum has ended a pregnancy affected by DMD. So what we know from this is that if needed, we've got potentially have some family samples for the testing. Anna and George explained that they actually would be very keen to learn about whether the pregnancy is affected, because they would consider altering their management of the pregnancy based on this result. So we very much support couples in whatever decision they make in a pregnancy, and we would support them through this pathway if that's what they choose. So the couple decide to have NIPD, and we are able to source the relevant samples to facilitate haplotyping NIPD. So an early scan's arranged for Anna at 8 weeks, and because she's over 8 weeks, the midwives kindly take the blood samples for the NIPD. A week later, we learn that the pregnancy is predicted to be male, and then so the DMD testing is initiated. 2 weeks later, the testing predicts that the baby is unaffected, so the couple are very pleased. Another example is Lara. So she's about 8 weeks pregnant, also her first pregnancy. She attends her booking appointment and she explains that she's well and her partner is well, but he's known to have a genetic condition, achondroplasia, which is a non-lethal skeletal dysplasia. So it causes very significant short stature. Lara and Andrew would like to have genetic testing in the pregnancy. Andrew explains that although he's well now, when he was younger, he had quite significant medical problems, and they want to know if their baby's affected by the condition. So this condition's a dominant condition, so the risk in the pregnancy is 50-50. So we know that Andrew has a change in the FGFR3 gene, and it's possible to offer NIPD for that gene change found in the dad. Because dad's affected, it's already been worked up to be able to test directly for that gene change, so we can offer NIPD. So we go through the options in pregnancy with the couple, and they decide to have NIPD. And likewise, they have their scans taken at 8 weeks and their blood sample taken for NIPD. Up to 2 weeks later, they learn that the baby has inherited the gene change causing achondroplasia. The couple are very committed to the pregnancy, but what this has allowed us to do is to be able to offer additional scans in the pregnancy. And what we know with this genetic condition, that the baby's head can be relatively quite large, and so there may be sort of delivery implications. So maybe a C-section would be considered for for Lara. So that's been really helpful to gain that information in pregnancy. And very quickly, conscious of time, we'll whiz through this last one. So Lucy, they've got a daughter affected by cystic fibrosis. Her and her partner are known to be carriers. She comes to us, and because they've got an affected child, we can offer CF tests, NIPD for CF using haplotyping. And as Beth explained, no workups required for this testing. The couple can, of course, have invasive testing or no testing at all. So we meet with the couple and they explain that they're very keen to learn whether the pregnancy is predicted to be affected. They wouldn't alter their management, but they feel that they really need this information psychologically to help them prepare for having 2 trials with CF, potentially if that's the case. So in this scenario, we send DNA from mum and dad and the affected child, Sophie, to Birmingham, and we get a blood sample from mum. And 2 weeks later, the baby is predicted to be affected by CF. So we have a follow-up call going through that information with the couple, and they also have an appointment with the CF team. And we know that the baby is actually eligible for gene therapy based on the gene changes for CF in the family. And that's me done, and very happy to take any questions.
Thank you, Steph. Thank you. That was fascinating and brings also the lab science to life, really, with real case studies, and shows us how it's used in practice. I think the key message, lots I could say, but I think the key message is early referral, isn't it? It's ideally before people get pregnant, but if not, as soon as possible in pregnancy, and not just in Leeds, but in all clinical genetics units around the country. They have facilities for midwives being able to ask those questions by email and picking up the phone, just to see if NIPD might be possible to get those families seen as soon as possible. I'm just going to share my screen. I am aware that time is moving on and we're almost at the end, but we've just got a few more slides. There, hopefully you can see NIPD and genomics, where to find out more. And I'm just going to hand over to my colleague, Denise. We're just going to show you where you can find out more information.
Thanks, Karen. Yeah, so hopefully your brains aren't too overloaded. We've shared so much information. It's been fascinating today just to hear both sides of the lab and the clinical genetics service. So what you can do now is, rather than spending the evening shopping on Etsy and losing yourself in there, you can lose yourself in GeneNotes. So GeneNotes is an online resource which stands for Genomic Notes, and it's meant to support you in the clinical field when you have a family with you that you're not quite sure what to do with. So you can go into the GeneNotes, you can look into the fetal and women's health section, and there's other sections around. There's lots of different sections being created, and they're split into 2 sections. One is in the clinic, which is built around clinical scenarios, similar to what you've heard from Steph and Beth's examples today. And one is the Knowledge Hub. So you'll be able to find more about cystic fibrosis. You'll be able to be exposed to a clinical scenario where maybe a pregnant woman knows her carrier status but her partner doesn't, and what you should do following that that scenario. It links to the National Genomic Test Directory that you've heard about, which standardises the tests that are offered in England and what's funded, who's eligible for those tests and who can offer those tests. So it's a really good resource to link in with, just to expand your knowledge a little bit more. And then it links through to the Knowledge Hub. So if you lose yourself in cystic fibrosis, want to know more about that in a bit more detail, you can link into the Knowledge Hub and find out more. Next slide, Karen, please. Thank you. And these are just a summary of some of the resources you can use to further your education into genomics generally. We've got really small bite-sized learning in the National Genomics Education Programme all the way through to a master's, and the master's and PGC are usually funded. So again, if you're looking at expanding and raising your profile in your midwifery or healthcare professional career, it's unusual to have funded courses now. So this is a real opportunity not just to expand your education, but also to look into genomics in a bit more detail. We've also got the e-learning for healthcare portal, which is migrating into the Learning Hub at some point. And on Future Learn, we've got these massive open online courses, or MOOCs, which again really links in and expands your knowledge on genomics and pregnancy.
We've also got a new innovation. It's the Genomics Learning Passport for Midwives. And the idea behind this is there's lots of resources out there, as Denise has just informed you, but sometimes it can be hard to know where to start. So the passport has been developed to guide midwives around those key resources, starting at the basics, starting at what is genomics, what is DNA, what is a chromosome, and then taking you through more complex courses, including courses for specialist midwives midwives, right up to master's level. And as you work through these learning resources, you can then record them in a format that is suitable for revalidation, and you can create your own sort of passport, your own sort of genomics learning journey, if you like. It's a Word document, so you can download it and then edit it. So if there's courses in there that you don't need to complete or aren't relevant, you can delete them. You can cut and paste it into your CPD activity log. We were going to put the link in the chat so that you can go there and have a look at it. It's a long document, but what our reviewers said was, yes, it looks a bit daunting to start off with, but if you just work through it slowly, chunk it down bit by bit, then actually it makes sense, and it sort of helps upskill your genomics learning.
And then we've also created a prompt card. So again, this is more designed for midwifery and community midwives, or someone taking a booking appointment history. What would highlight to you what a genomic red flag is? And a lot of people are asking the right questions at the booking appointment, but don't quite know what to do with that information when they've got it. So this is just a really quick reference guide. It was designed to be A5, so it can fit into a diary, really handy, and just a quick reference guide as to what to do with families when you think it's a bit genetic or a bit genomic, I don't quite know what to do. It's got all a little list of genomic red flags on one side, and on the other side it's got your contact details for your fabulous clinical genetic services that you have to work with. They're fabulous to work together with, and they've been created to be shared across each GMSA, so you've got the local contact details. They're available on our North Eastern Yorkshire genomic website because we created them, but we've shared them, and so each GMSA will have their own version that you can link in with and expand your knowledge that way.
Thank you, Denise. So we've come to the end, apart from any questions. So there is a QR code there for a feedback on the webinar. It also gives you an opportunity to sign up to our GMSAs and to our mailing list, so you can hear about more events in the future. And also you'll be sent the link to this recording. If you've got any questions though now, I know there was a couple in the chat, so hopefully you can see them there. But if anyone wants to put their hand up and ask any questions, then please do. And while we're listening to any questions, then yeah, don't forget to fill in that post-webinar feedback form.